let's get back to women. Okay, so menopausal women, some menopausal women experience heavy bleeding. You kind of alluded to it earlier on, and you're what's happening there?
Your question is, some menopausal, perimenopausal women have heavy bleeding. Is that what I'm hearing?
Yes.
Yes.
Or a menstrual cycle that doesn't seem to stop.
Yes.
For weeks.
So remember, there's a couple of reasons. So the first is it a heavy bleed because they're having an anovulatory cycle that has to do with ovulation? And then there's another thing about, is it the structure of the uterus and the lining of the uterus that has inflammation at the blood vessels that are making it difficult for the microvasculature to constrict? And so there's two things. So the first is that if it's an anovulatory cycle, because perimenopausal women might not be ovulating every month anymore, then the progesterone withdrawal from ovulation never occurs. And so the lining of the uterus just tends to grow and grow and grow and grow and grow with estrogen unopposed. And so you need that estrogen in the first half of the month, and the second half of the month is the progesterone that comes to stabilize the lining of the uterus. But if you never have the ovulation that brings about the progesterone, then the lining of the uterus will just grow and grow. And then randomly, 1 or 2 weeks after your menstrual cycle is supposed to come, you'll just have these breakthrough bleeding episodes that last a long time. And that's just because there's more lining to shed off. And it just is prolonged and unexpected, and usually doesn't come with that much cramping or pain. So that's one piece of anovulatory cycles that can lead to heavy menses, but it's not really a menstrual cycle. It's just the shedding because the lining of the uterus has outgrown its blood supply because it's so thick. Now, and then the term of heavy menstrual, of bleeding from heavy or from regular ovulatory cycles, the older we get, the more endothelial inflammation that we have, and that's cumulative, right? And so, the lining of the uterus is just one big smooth muscle, layers and layers of smooth muscles. And that inflammation at the level of the intima of those blood vessels make it difficult for those blood vessels to constrict when it's finally time to stop bleeding. So normal menstrual cycles should last no more than 5 days. But a lot of people are longer than that because of the impairment of the spiral arteries, which are the blood vessels at the lining of the uterus, and they're not constricting. So the people are just flooding and bleeding these prolonged cycles. A lot of patients get very frustrated because they get pelvic ultrasounds done, and the pelvic ultrasound doesn't show fibroids, or the uterus is normal, but they're like, why am I bleeding? It's because the pelvic ultrasound doesn't look at the microvasculature. And so, then we just have to think about, okay, it's probably abnormal uterine bleeding, AUBE, from the endometrium, the lining of the uterus. And so Angela and I have talked about this a lot, where a lot of times patients start as salt tablets, and then their bleeding is a lot lighter, and it has to do a lot with those sodium channels, and also with magnesium too, with the channels to help constrict, to allow muscles to actually contract and do their thing. And so that happens at the level of the lining of the uterus, the smooth muscles too. And so Angela talks about all the time where she has these migraineurs that say, oh, my periods are much lighter, or they're better. And it has to do with the sodium and magnesium response at the level of the contractility of the spiral arteries at the lining of the uterus. So that's, it doesn't just have to do with perimenopause, that could be, just from, chronic inflammation at any phase of life. But those are the two big players.
We talked about all of the relevant hormones except testosterone. Does it play a role in menopause, or even when it comes to migraine? Does testosterone level make any difference?
Go ahead, Angela, with the testosterone and migraine. That's interesting.
Very few women that I read a lot of blood tests in my group. And of course, women very seldom take testosterone. I have maybe 3 or 4 who are older, and they will take testosterone, and I see their blood tests way up the chart. And I would suggest that, yes, I see a little bit of an increase in their potential to get migraine, but I don't know if it is directly the result of the testosterone or as a result of what other changes that makes in the body. That I don't know enough about it to actually know. But what I do know is testosterone is a hormone that is supposed to be a very small amount in a female, and maybe it is the kind of excitatory hormone, such as the androgenic hormones like adrenaline and similar. So I'm not sure, but if that is the case, then that would initiate more sensitivity toward migraine, because adrenaline is part of the migraine cycle, which I refer to as a tri-migraine complex. So that's part of the fight or flight that is actually initiated by the brain when the brain is running low on sodium because it's not able to work. So it is going to initiate a fight or flight to increase the blood flow to the brain. And of course, that comes with a lot of extra glucose as a result of glycogen. So we have a lot of combination of factors here. So I don't know how testosterone fits into this, but I'm just thinking that it may be a little bit more stimulatory toward the stress hormonal setup. I'm just thinking that. But Andrea, what's your take on that?
Yeah, I don't know a whole lot about testosterone as a whole. You would think that we would more, and as gynecologists, and we do know that it does help increase libido. And I'm actually going to be taking a course sometime soon about looking at testosterone specifically, because we do know that one of the big cautions for a long time was to not take testosterone in perimenopause or in postmenopause for large doses or for too long, because aromatase does bring it back to estrogen, and then it turns into an unopposed estrogen state and increases the risk for uterine cancer. A lot of the newer data shows that that's not quite the case anymore. And so I find that fascinating. But when I was in training for many years, we were told really not to give testosterone for more than 6 months for libido because of that conversion. But yeah, I mean, there's so much. I think it's a hormone that a lot of folks in gynecology were a little reticent about giving and feeling a little more comfortable. But there's a lot of people out there in the functional medicine space that are very liberal with their use of it. But I'm going to say that I don't know enough about it to make really good recommendations of where it fits. But I do think that in terms of the fight or flight mechanism and stuff, and how that relates to migraines and trauma is very interesting. And then we know that very much relates to women's health as well, and the feeling of safety, but also with endometriosis too. So I think that has new avenues for us to study, Nayiri. So thank you.